Welcome to the CodeCast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast Podcast today. My name is Terry Fletcher. We have hit our 200th episode. Can you believe it? I'm very excited about that. Consistent every Tuesday, and we have not missed a Tuesday since November 1st, 2017. So kind of an exciting milestone for us, I think. We're also at 238,889 downloads. So again, thank you to the listeners and everyone who really sends some positive feedback to me and lets me know what you think of the CodeCast podcast. Also, if you get a chance, just a reminder, please rate us and give us a review on anywhere you listen to your CodeCast. So on Apple, on Stitcher, iTunes, YouTube, you name it, they have a way to send us a review or rate us. So we appreciate it. And we are now on 25 platforms, including Amazon, you name it, we're out there and getting picked up weekly. So today I want to talk to you about documentation as it relates to coding. So there's a saying that says there is no coding without documentation, and doctors are required to use their words. So it was interesting because I was reading an article in rackmonitor.com, and I was having a conversation this morning on a webinar training that I was giving. And a lot of the conversation was, well, can we go ahead and code for that? Because the doctor put the code in the encounter information in the patient's record, but there's no narrative discussion of it. Well, AHIMA, American Health Information Management Association, who touts the rules and compliance when it comes to ICD-10, and AHA, the American Hospital Association, they're the ones that actually write policy in addition to CDC and the World Health Organization on diagnosis coding. They stand behind that statement that doctors are required to use words and there's no coding without it. And more I'm seeing coders making leaps to moderate, even high risk on certain encounters for patients when there's no link narratively in the record made by the physician. So I want to talk about this as a compliance issue and a coding issue. So in the Coding Clinic article, and again, the Coding Clinic is from the AHA, they make policy and direction on how to use the ICD-10 CM codes and ICD-10 PCS codes. They are the body that not only makes policy, but they also publish quarterly and updates and yearly updates when it comes to these policies on how to use our official guidelines, how to code for certain things. And it's important that you really understand this concept because I think there's some things that are missing right now. And with a lot of the audits that Medicare, federal government, and now private payers have now decided to reinstate, even though we still have a public health emergency federally going on, it's important to know about these policies. And so a question came up during the fourth quarter of 2015 on whether there is, and I'll quote, an official policy or guideline requiring providers to record a written diagnosis in lieu of an ICD-10 code number in their documentation. The Coding Clinic says yes, doctors are required to write words, and they go on to remind coders that ICD-10-CM is a statistical classification. The role of physician documentation is inherent in the use of the code set because the process of coding is really the translation of physician documentation into codes. So before we even get to the first convention in the documentation rules in ICD-10, the preamble to the ICD-10-CM official guidelines for coding and reporting, it reads this. It says, and I'll quote, adherence to these guidelines when assigning ICD-10-CM diagnosis codes is required under HIPAA. The diagnosis codes, tabular list, and alphabetical index have been adopted under HIPAA for all healthcare settings. A joint effort between the healthcare provider and the coder is essential to achieve complete and accurate documentation, code assignment, and reporting of diagnoses and procedures. These guidelines have been developed to assist both the healthcare provider and the coder in identifying those diagnoses that are to be reported. And then it says the importance of consistent, complete documentation in the medical record cannot be overemphasized. With such documentation, accurate coding cannot be achieved. And they italicize that last sentence. So it's interesting when you actually look at this from a policy perspective The preamble tells us, three important things. First, it cites the law that makes ICD-10-CM our official code set for diagnoses, which makes adherence to the official guidelines mandatory. Second, it explicitly tells us that not only is physician documentation required, but it must be consistent and complete documentation. And then third, there are two parties required for the code set, providers and coders. It's not a standalone service. So providers are responsible for the documentation, and us as coders are responsible for translating those words into codes. So when you look at this and really look at the nature of all of the classification, a code is not the same thing as a diagnosis. Remember, it is the translation of a physician's diagnostic statement, so again, their words, into a code. The title or descriptor for an ICD code is not the same as a diagnostic statement. Codes should not be considered shorthand for their descriptors, and instead a code title is a kind of shorthand for the fullness or completeness of what each code can represent. So the code book does have words, and coding is a language, as we know, but it also comes with rules. So the code book has words that are in alphabetical order, but it's not a simple list, and it doesn't have just a one-to-one correspondence between entry and code. It's really an index with main terms and subterms. And once, as a coder, you locate the number, the next required step is to take that number over to the tabular list, read and apply any instructional notes, inclusion terms, exclusional notes, to verify that the code is correct. And remember, if it isn't, you have to start over again. So the classification system is a constantly evolving language with rules, conventions, and definitions. So in a physician's diagnostic statement, if you have something that says with or and, what does that mean within the rules? What is a principal diagnosis? What can qualify as an additional diagnosis? What codes can, never be reported together, and what codes are supposed to be reported together? Because some codes have to be reported together, and there's also certain orders that the rules tell you that has to happen. So if doctors have the time and interest to really look at this language and become fluent in this language, that would be amazing, because then it would relieve them of having to pull out these codes, but allow for the coders to be able to supply codes from that documentation. And why do we need our coders? So even if the doctors were aware of every coding nuance and rules that apply on which dates of service, what if they misinterpret or if they forget? How would we know? And without documentation, again, that narrative documentation, there's no way of verifying or even questioning the accuracy of the code selection. And we wouldn't be able to query them, since code accuracy only has meaning in relationship, again, to the physician documentation. So imagine one physician basing a life or death medical decision on another doctor's notes rather than his or her diagnostic statement. Imagine that decision leading to an adverse event that ends up in a courtroom. Instead of documentation, all we have is the physician's list of codes. Or imagine a payer wanting to know if the payment they made for a case was fair and accurate, and instead of documentation, again, all that's available is a list of codes that are identical to what was submitted on the claim. No one would be good with that. No one would be okay with that. If we see where the coding, where the code is enough path takes us, it kind of gets ridiculous pretty quickly. In addition to a deep understanding of the rules and mechanics of the use of the codes, medical coding requires a solid foundation, or at least some expertise in anatomy and physiology, medical terminology, pharmacology possibly, disease processes, along with the skill to interpret documentation. And sometimes it's less than optimal sometimes with coders, and so we have to have that physician input from a narrative perspective. Also, coding is seriously, in my opinion, an undervalued profession. So what's tough sometimes is what the lack of understanding of what coding actually entails, and we try to talk to the doctors about this. Coders are entrusted with turning medical encounters into data, legal documents, and as a society and as a healthcare professional, I value that healthcare data, that accurate healthcare data. We want to be able to analyze outcomes, establish protocols, identify disparities. You look at what Medicare does, allocating resources and reimbursing providers based on the entire clinical health profile of that patient. So not only should we really look at appreciating and supporting our coders, but we have to make sure that there is open communication with our physicians so that they understand what we're dealing with when it comes to extrapolating codes from their information. Otherwise, it's not going to work. We have to be able to maintain a communication between our physicians and our coders. And I know it's a challenge because both parties are so busy, but this communication can make a big difference to both the physician, the hospital, the Part B services in the office, because those interactions, when you're trying to code and pull out information from the record into what would be a medical claim, is going to affect your reimbursement. So we really want to not only use medical or mutual respect, but we also want to make sure that physicians are understanding that proper documentation leads to increased reimbursement, while incorrect or inadequate documentation is not just a lower reimbursement issue, but it raises compliance issues and pretty much a risk in what could happen if you don't follow the rules and regulations. And so it's definitely important that we have that conversation with our physicians about making sure they're giving us everything we need in a narrative standpoint, and then let us code it. We're the coders, let us code it. Just give us your thought process and everything that goes into it. Conversation that I had this morning when I was doing a presentation for a practice in Chicago. One of the coders asked a question about, if they put just blank pain, can we automatically assume on an E&M service, because we are an urgent care center, that that's an undiagnosed new problem with an uncertain prognosis? And I'm like, no, where's the pain from? It could be just is it a thumb pain? Is it a chest pain? And are there any kind of risk factors around it? What exactly is going on with that patient? You can't make the leap or the link even to a moderate or higher visit if you don't have more detail. So it's really important that the physician give you as much information as possible, especially when we're talking about chronic illnesses. Think about that. If somebody says the patient's had ongoing ear issues, would you give them credit for a chronic illness under the moderate number and complexity of problems addressed for one or more chronic illnesses? I would not. But what if the physician put in there several previous episodes of otitis media, right ear, was treated with so-and-so, did not help, and now the patient presents with another episode in maybe the 6th in the last 5 months. Now you've got a chronic illness with exacerbation, progression, but you have to have that narrative detail. And if the doctor just put in a code versus that narrative information, it's not going to be enough, and it could be definitely a compliance risk. So we want to just make sure that we're clear, not to be leading, not to read into anything, but hopefully everybody's communicating together from the narrative to the coding, and then making things compliant. So my coding question today actually takes us in an interesting direction, and it has to do with medical nutritional therapy, so MNT. And Medicare does pay for that, but there are a lot of guidelines and frequency rules and who can provide the service, etc. So make sure you're reading up on that. But here's what the question says. It says, Terry, we're providing services under the MNT, and we know we're supposed to be billing 97802 to 97804, whether it be a individual patient or group patient, and we're using time to define what we're doing. So we understand those rules. But something's come up recently as far as a referral to those services. Our nurse practitioner is referring to our dietitian that bills under our physician. Is that okay? Actually, no. So actually under the Medicare Part B, Section 1861, under the Social Security Act, and under the Medicare services, it says that MNT can only be provided based on a physician referral. As a result, an NP or PA cannot refer a Medicare beneficiary to an MNT program, but they can write a referral for a DSMT. So that is a diabetes self-management training. But you have to make sure you know that, diabetes, chronic kidney disease, kidney transplant within the last 3 years, and it cannot be performed by a dietitian under the physician or qualified healthcare provider. Yes, but it has to be referred by a physician, not a qualified healthcare professional. So just make sure you're aware. Medicare has a tip sheet on that. If you are a Coding Corner client and you need a tip sheet, just email me with your account number and we'll make sure that we get that over to you. So those are big deals because they're, OIG and CMS, they have so many audits that are going on right now, and that is a big one, trying to recoup money from all the money that they've been pushing out. Our coding question is brought to you today by CeraVe Daily Moisturizing Lotion. Daily moisturizing lotion for normal to dry skin. Moisturizes and helps restore the protective skin barrier. Developed by dermatologists. CeraVe, C-E-R-A, capital V-E. Okay, so I'm going to end with my personal tidbit this week. My remodel, my house is finally done. I know I've been kind of talking about that. So I moved in about a month inland from the beach into a new single family. Well, now it's new. It wasn't before. We hadn't been remodeled since 1968. So that house is now all new inside. It's everything. I'm starting to put furniture in it and everything. But I am moving an hour inland. So now instead of always, for the last 35, 40 years, I've been about a mile from the beach. Now I will be an hour. It's going to kill me. And I was nervous before, but I'm telling you, I'm excited just to go back to single family house instead of condo living. Right now I live on a golf course and it's beautiful. Love my view, but I am ready. But now I'm going to see what a pool will cost. And from what I've been told, my budget is about a third of what they cost. So I have a feeling my husband's going to get his backyard putting green over my pool. Just saying. But stay tuned on that. I'll keep you posted. Also, as a reminder, telehealth consents. Remember when the public health emergency first started back in March of 2020? We were able to get those consents for 1 year. Well, guess what? We're now 17 months into the pandemic. Have you updated your consents for patients who are still getting telehealth services under the public health emergency? They've probably expired about 5 months ago. So you must make sure you update those again because telehealth, and I'm going to remind you, during the public health emergency, Part B encounters are under the OIG work plan for audits, and they are really auditing big time. So just make sure you get those consents re-signed so patients understand that they will have a share of cost, what it means to have a telehealth visit. Make sure you're still using the audio and video for any office visits that you are reporting. Okay, that's it for me this week. Make it a great day, and I will talk to you next week on the CodeCast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.